Morning, everybody, and welcome to the second day of the International Health Workforce Collaborative. And I'm really pleased for us to be kicking off this second day, our policy day, with a panel on the WHO review undertaken on health practitioner regulation. As I mentioned before, I'm Ivy Giorgio, and I would like to pass over now to Jean Moore, who's going to be the moderator for this session. Over to you, Jean.
Thank you, Ivy. Hello, everyone. So for a little background, in 2021, the World Health Organization commissioned an extensive review of the literature on health practitioner regulation. And the review was undertaken by a multi-country research team. The team examined the diversity of regulatory principles, elements, approaches to developing, implementing, and strengthening health practitioner regulation. Based on this review, and along with input from a technical expert group, the WHO will soon release its first ever guidance on health practitioner regulation. Today, we will have the opportunity to hear from members of the research team, the WHO, and the technical expert group about this important initiative. Our presenters today, Kate Leslie, member of the research team at the Athabasca University in Canada. Anne-Louise Carlton, also a member of the research team, Senior Policy Advisor, Healthwork International Australia, and Vivian Lin, who is based at the Hong Kong University. Giorgio Cometto, who is at the WHO, will also be presenting, as will Jishnu Das, who is at the Georgetown University and was a member of the technical expert group. So we will start with Kate.
Thanks very much, Jean. I'm just going to share my slides here. So thanks everybody for joining us today. I'm really happy to start off our panel discussion. Anne-Louise and I will be sharing our presentation today. So I'll kick us off and describe the review process. And I'm going to turn it over to Anne-Louise, who will dive into some of the key findings from the review. And then I'll wrap it up before we pass over to Vivian. So to start with just a little bit of background here, as Jean was mentioning, this was in early 2021, this started. Our team, led by Vivian, submitted a bid in a competitive process to complete a review of the global literature on health practitioner regulation. And then this review is what's being used to inform the global guidance from WHO. It was a very large team effort. We have a full list, pages long, of acknowledgements in our report. But just to know, it was a really major undertaking. We could not have completed it without many hands. I've listed the research team here just in order of the authorship on our main findings manuscript. Big thanks as well to Giorgio and Agia from the WHO, and of course the technical expert group on health practitioner regulation for all the guidance and the feedback throughout this project. So this was a large-scale systematic process for our review. We started in summer 2021 once we'd secured the contract to identify and refine the review question. WHO had a set of topics that we were to cover, and we spent some time organizing that into a conceptual framework and guiding questions for the review. In phase 2, we completed a very comprehensive search strategy. In phase 3, we screened those sources to identify relevant academic and gray literature sources. In phase 4, we appraised all of those sources and completed data extraction and synthesis. This is obviously a slightly simplified version. There's a lot of iterative work going on throughout this. But generally, in our final phase over the late fall of last year and through early of this year, we finalized the writing and revision of a final report and manuscript. Throughout this process, we had consultations and reviews with the WHO and the technical expert group. We had a lot of guidance and feedback on our findings and validating what we were seeing and getting some more information and sources as well to include. And then we always kept in mind as well that we were finding the evidence that was meant to provide the evidence needed to support the WHO process in developing their guidance. And Giorgio will speak a little bit to that today. So phase one, identifying and refining the question. When we started the review, this was the overarching review question that we were commissioned to answer. So what key considerations, common principles, core elements, and recent innovations can assist jurisdictions in designing and delivering more effective health practitioner regulation to improve patient safety and the quality, capability, effectiveness, and sustainability of the health workforce and achieve health system goals? So as you can see, this was a very big question with a lot of different components to it. So what we did first was to try to organize this into a guiding conceptual framework. We used a modified Donabedian framework, so structures, processes, and outcomes. So structures, we were thinking about the context of regulatory systems. And here we asked, what contextual forces and structural characteristics shape the design and delivery of health practitioner regulation functions, and what are the key challenges that governments and regulators face? Under processes, we looked at the typical activities associated with regulation and asked, what are the main functions and activities of regulatory systems, and what are the different approaches and models and tools that are used to deliver those functions? And then under outcomes, we looked at the impact and effectiveness of regulatory systems. So we wanted to ask, how effective are the various approaches and models of regulation in actually improving safety, quality, quantity, capability, and effectiveness of health systems and workforces? So still a lot to cover, but we found that this conceptual framework really helped organize our review process, and then we used it to organize and present our findings as well. So we conducted a large review. We used 14 different academic databases and extensive gray literature searches to find our relevant literature. We did a lot of hand searches, citation tracking. We assessed sources in 5 languages. So this is our Prisma diagram. And just to note, this is just for the academic literature. So after we removed duplicates from our search, we had 2 reviewers that independently screened close to 32,000 records. We reviewed, again in duplicate, almost 1,200 full text records and ended up including 410 academic articles in the review. Our gray literature, where there was a lot of very relevant evidence that we were finding, included an additional 426 sources. So we extracted data from these sources and synthesized the data. And here, again, we structured the findings first by structures, processes, and outcomes per our conceptual framework. And then we found a series of topics under each of those structures, processes, and outcomes. And then underneath those, we found themes within each of those topics. So in our manuscript, we have a key findings table and a mapping image that shows how this all relates together. So we have 2 main outputs from our project. The first is a manuscript published in Human Resources for Health. I can post the link, but also if anyone in the room or online, you can hold up a device to that QR code and it will take you straight to our open access manuscript. And then we have a more comprehensive report. It's just in its final stages of being sort of copy edited and finalized, and then that will be posted on the Canadian Health Workforce Network's website. So we'll have that available. For now, we've got the open access manuscript where all of our key findings are highlighted. I'm going to pass it over now to Anne-Louise to talk to some of our key findings.
Thanks, Kate. So to begin with, our task was complicated by the lack of widely accepted terminology and standardised typology for health practitioner regulation. So in one of the early chapters of the report, we did 2 things to try and address this deficiency. The first is we came up with a glossary of terms where we've offered definitions that we think go some way to addressing the confusion with terminology, particularly around commonly used terms such as registration and licensing, accreditation, and self-regulation. The second thing we did was to define the term occupational regulation and offer a typology for classifying different types or models of occupational regulation. So we've identified 4 types: statutory registration, or commonly called licensing. The most common type, co-regulation, various schemes. Voluntary certification, also very common, run by professional associations. And a 4th type of occupational regulation that's not that well known, we're calling negative licensing. We found these latter schemes in some Australian states and in the state of Minnesota in the US. In Chapter 4 of our report, we describe the literature on the scope and governance of regulatory systems. So under structures, we've started with the big picture and then we've gradually drilled down. Not surprisingly, we found considerable diversity in how countries organise their institutions to deliver the regulatory functions that we cluster together under the term health practitioner regulation. In some countries, regulatory functions are spread across a range of government and non-government bodies rather than consolidated into a single regulator or regulators like in Anglophone countries. We looked at how countries make regulatory policy decisions about which professions to register or license. We found that most OECD and ASEAN countries now have in place regulatory management systems that require compliance with good regulatory practice. And this generally includes a regulatory impact assessment for new or amended regulation. Some countries have also developed regulatory assessment criteria and processes to help make decisions about which professions should be subject to statutory registration or licensing. In Chapter 5 of the report, we look at the literature on regulatory institutions, and again, we found a diversity of arrangements. We found some governance trends, such as multi-occupation regulators and umbrella laws were evident. But because of the lack of standardised typology, it complicates comparison of these governance arrangements across jurisdictions. Most studies we found focused on statutory registration schemes, and evidence suggests that this model of health practitioner regulation is increasingly being implemented in many jurisdictions and for many practitioner groups, including in low and lower middle income countries. We found very few studies that compared different governance models or assess the effectiveness of different approaches. We have offered some suggestions as to what researchers might look at to make useful comparisons between governance arrangements of different regulatory schemes. We did find some regulators have started applying the tools of risk-based regulation using data analytics to inform strategies for harm prevention and minimisation. Certainly, multi-profession regulators have an advantage in that they have more data to work with and greater economies of scale to finance this type of work. In Chapter 6 of the report, we look at the literature on what we call system linkages. That is how regulatory schemes and regulators interface with or link or partner with other regulators and other broader mechanisms of quality assurance, such as in the education sector, health facilities licensing, public health regulation, drugs and poisons regulation, and importantly, the Ministry of Health's stewardship functions, such as workforce planning and development. We found very little literature that addressed such linkages and no literature that evaluated the effectiveness of these partnerships. We did find an important link between health practitioner regulation and government workforce planning functions. In some countries, regulators are empowered to collect and supply to government comprehensive workforce data set that can be used to improve health workforce planning, development, supply and distribution. This is an important function that was crucial to governments during the pandemic to support a surge workforce. In terms of regulatory processes, there were 5 chapters under this heading. This is a new slide, Kate. The first, Chapter 9 of the report, we look at the literature on scope of practice and how scopes of practice are regulated in different jurisdictions. We found a diversity of approaches and differences in the role and powers of regulators. We found an emerging literature comparing different approaches across countries. My colleague Kathleen has been publishing some useful comparative work on this topic. We also found this topic yielded by far the largest body of literature, mostly from the US, and the evidence shows that in many cases, both regulators and regulations have not kept pace with the demands for greater flexibility arising from collaborative team-based care and a more dynamic division of labour that better supports innovation in healthcare. The evidence supports the imperative for governments in some jurisdictions to change the way scopes of practice are regulated and to accelerate the pace of workforce reform, particularly with respect to the prescribing of restricted medicines. The imperatives created by the pandemic have demonstrated how quickly scope of practice reforms can be implemented, and we've certainly found that in the literature. In Australia, we found negative licensing provides a safety net for consumers who use the services of non-registered healthcare workers by empowering regulators to remove unfit workers from the health workforce where they present a serious risk to public health and safety. Slide 10 on accreditation, Kate. In Chapter 8 of the report, we looked at the literature on the regulatory functions of accreditation of education providers and programs for entry to practice. Again, we found considerable diversity in how the quality of entry to practice programs is assured. Some jurisdictions have national or subnational licensing examinations. Some rely on accreditation of education programs and only examine practitioners from non-accredited programs. Some have both a national licensing exam and accreditation of programs. We found little evidence of the effectiveness of accreditation and no comparative analysis of different approaches. But despite the diversity of arrangements, the core elements of accreditation appear common across jurisdictions, and accreditation is seen as an important tool for assuring the quality of programs and progressing, and also increasingly progressing broader social goals. Slide 11 on continuing competence. In Chapter 7 of the report, we looked at the literature on the registration functions more broadly, including how regulators ensure the continuing competence of their registrants. We were also looking at literature on how public registers are maintained, and the literature on internationally educated practitioners, how they are assessed, supported to transition to practice, and of course any literature on the impacts on source countries, which I think Giorgio will talk about a bit later. Most of the literature we found was on continuing professional development, and there was reasonable evidence about the effectiveness of mandatory CPD as a condition of licensing or registration, as long as issues such as access, equity, delivery and design and assessment are addressed. We found some evidence of the effectiveness of programs designed to support transition to practice for internationally educated practitioners. In Chapter 10 of the report, we looked at the literature on complaint handling and disciplinary functions of regulators. And again, we found considerable diversity in the architecture of these functions, the powers, the governance, and the processes. And again, little evidence on how to best design and deliver effective systems. Some regulators are using data analytics to identify hotspots of risk and design harm prevention and minimisation programs, and we found some evidence of the effectiveness of remediation programs for impaired or poorly performing practitioners, and some studies of the role of mandatory reporting as an effective public protection strategy. Slide 12 on T&CM. In Chapter 10 of the report, we looked at the literature on occupational regulation of traditional and complementary medicine professions. We found evidence that statutory registration is increasingly being extended to more of these professions in more jurisdictions in response to evidence of risk. We found studies that suggest that registration or licensing works equally well for the established and widely practiced T&CM professions with some adjustments. Statutory registration can not only strengthen public protection for these professions based on their risk profiles, but can be used to preserve Indigenous medical knowledge and improve health service delivery to underserved populations. Again, regulators with negative licensing powers are issuing prohibition orders to remove from practice those who operate within these paradigms, but also present a serious risk to public health and safety because of their misconduct. Slide 13. Impact on workforce and system outcomes. In Chapter 12 of the report, we looked at the literature on the effectiveness of occupational regulation in achieving outcomes for the health workforce and the health system. We found very few jurisdictions have institutionalised arrangements for periodic review and continuous improvement of their health practitioner regulation arrangements. Only in British Columbia, Ontario and the UK did we find organisations with specific responsibility for scrutinising the performance of regulators and recommending changes to legislation or regulatory powers to ensure that regulation remains fit for purpose. We found considerable scope to use the tools of health practitioner regulation to better support the achievement of broader social objectives, such as reducing inequality and increasing diversity, eliminating racism from the health system. And we're starting to find some evidence of these powers being used. We did find pockets of what we would describe as innovation, particularly in the use of risk-based regulation and data analytics, using regulation to achieve broader social goals, and also some innovation in regulatory models such as the Quality Assured Voluntary Registers program in the UK, negative licensing schemes in Australia, and also the ARC linkages projects in sub-Saharan Africa. Final slide, final slide, I think. In Chapter 13 of the report, we looked at the literature on regulator responses to the COVID-19 pandemic. It was a bit too early to find much in the published literature on the effectiveness of regulatory responses to the pandemic. Most of the data that we found was in the grey literature. There was a strong theme that restrictions on scope of practice and barriers to portability of licensure constrained the ability of regulators to respond in a timely way to support the needs of a surge workforce. We also found that those jurisdictions with good regulatory practice requirements, such as regulatory impact assessment, eased these requirements to facilitate more timely passage of newer amended legislation. And at this point, I'll hand back to Kate for the knowledge gaps and conclusions. Thank you.
Thank you so much, Anne-Louise. So I'll just quickly acknowledge, some of the gaps that we found and some of the limitations to our review. There were a lot of knowledge gaps around the outcomes and effectiveness of specific regulatory processes, and particularly how these may vary between jurisdictions and practitioner groups. There were limitations in the evidence base, and I think Jishnu and Vivian may get into that a little bit more. But this included the dominance of high-income Anglophone countries. We had less evidence coming out from the low and middle-income countries. So our themes and findings strongly reflect matters of interest and contention in high-income Anglophone countries. There was also a dominance of descriptive studies in the literature. And of course, our search cutoff was September 2021. So there's been a lot of more recent research, particularly around the COVID responses, regulators' role in helping to address what is a continually growing workforce crisis, and newer issues like artificial intelligence. And these may have shaped our review as well. So to address some of these gaps, we recommend that future research prioritize regulatory outcomes. So research funders and governments can invest more in generating this outcomes-based evidence that will help inform regulatory design and reform efforts. A more standardized framework would also help to evaluate different institutional and governance arrangements and enable some stronger cross-jurisdictional comparisons of performance. A systematic approach to tracking and evaluating this type of research too would really go a long way to help the global regulatory community. Speaking of evaluation, as Anne-Louise was saying, there's a lot of scope for expanding regulatory research and evaluation. So in our view, some of these evaluations should look at the viable alternatives to statutory registration schemes, particularly for the lower risk occupational groups. They should look at how the regulatory reforms and innovations that were used during the pandemic, how effective those were, and whether any should be maintained long-term and which ones should be high on the priority list to be most useful for future crises. And finally, we found that in some jurisdictions, as Anne-Louise was saying, this broader mandate around broader social objectives was something that was becoming more part of what regulators were seeing as part of the serving the public interest. So we want to see a little bit more research too as we move into the future about how best to achieve those goals. So that's the high-level overview of our integrative review. I'm going to pass it now over to Vivian.
Thank you so much, Kate and Anne-Louise. Let me continue on and make some points about three categories of issues. One is the nature of the evidence and some of the issues we found, elaborate on that a little more. Secondly, some of the challenges arising from the review that we could see, and also some suggestions for what might happen next. Again, as Kate has already mentioned, the literature was dominated by the Anglophone high-income countries, which are also common law jurisdictions. So they actually miss quite a lot of the rest of the world, and the outcomes are missing. I think it's worth also noting that the literature was actually dominated by a lot of the American debates. And the scope of practice was a major part of that. So you have a sense that research is done to help address contentious issues, and that people want the evidence in order to help resolve issues. And given state-based regulatory arrangements in the US, and there are 50 states, each time the same issue come up, there's another bit of research. So it's interesting just to reflect on, therefore, why certain kinds of research questions are asked, who is funding that research, and how relevant it is for others. Now, we actually also looked at the French and Spanish and the Chinese literature. And what we found was that there are quite a lot of the literature that's about countries which speak Spanish or French are actually in the English language publications. And where are speakers of French and Spanish who review the papers in the original, they were the less good quality papers from a research design viewpoint. The Chinese literature is completely different in that it doesn't deal with sort of the regulatory processes, arrangements, but it actually relates to some of the very specific issues relating to controversies in medical practice and the complaints. So quite different. A lot more of the useful evidence and the policy recommendations came from the great literature, yet we have this approach of doing systematic review, which says it's the peer review published literature, which is the most important. But it seems that we actually can find more useful literature from organizations focused on policy and practice. Although in that great literature, one has to be very careful to separate out what is the evidence and how that's gathered from what is advocacy for certain positions by those organizations. So I think it's just, I wanted to highlight some of those issues in the evidence base. Now, I think some of the challenges then that arise from this kind of evidence base, then the first is to recognize that regulation is a political choice. it's not a simple sort of set of technical solutions, but it is context specific. And of course, that means it's not easy to just say, you should do this and you will have, you know, gotten the best possible regulatory system. So I think the dominance of this Anglophone high-income country literature then suggests that we really have to think about how do we learn about why something is in place, why it works, why it doesn't work, why particular debates, rather than think about how do we replicate it in the lower and middle income countries. And in the lower and middle income countries, what we see in the literature is quite often that both from a health workforce viewpoint as well as the regulatory viewpoint, there are models that come from the history of colonialism, or models that are being advocated by the global professional organizations, which are also dominated by Anglophone high-income country that are often also the former colonial motherlands. So I think we need to be really very reflexive and very cognizant about, is this the best advice? So Giorgio will obviously be addressing this set of issues, because in the absence of directly relevant literature in many ways, there is a need for normative guidance and being very mindful of very different contexts. And so I think that what's really important for lower and middle income countries is to really think about the context of the health system and what might be a fit for purpose workforce, as well as the capacity of a regulatory workforce, so that, you know, when you do decide to regulate, you're actually mindful of what's possible to implement as well. So where to next? Kate has mentioned a number of issues in relation to the research needs. I think that anytime you want to do comparative work, you have to make sure things are comparable. So the whole terminology issue is, of course, important, as is this very big gap in outcomes. But I think that it would be useful to also have a lot more research in lower middle income countries and in different types of legal jurisdictions, rather than just the common law jurisdictions. But beyond the research, I think where lower and middle income countries have a platform, the possibility of learning from each other, that would be very helpful. And I think we need everywhere to understand more how regulatory systems do not exist as silos or in a vacuum, and really understand better how we can contribute to health workforce development, health service development, health system improvement. And we could also probably learn much more from regulatory systems, the design implementation in sectors other than health, and be mindful about where health may not have all the answers or the best solutions. So let me leave my comments there. Thank you very much.
Next, we'll hear from Giorgio to give us some perspective from the WHO.
Thank you very much, Jean, and good morning and good afternoon and good evening to colleagues on the panel, in the audience, and around the world. A pleasure to join you today. And in the first place, I would like to acknowledge and congratulate both the review team that have just spoken, presenting highlights of the outstanding work they conducted, but also the members of the technical expert group. We have one on the panel who will speak after me. I acknowledge that we have one in the audience, Andrea Garapi, The considerations that I'm going to share now are really the results of a collaborative effort that WHO coordinated, but that would have not been possible with the contributions of the many people involved. The review team has given you the highlights of the evidence. They were closer to that. I will not speak much to that myself, but from our perspective, and I work in the health workforce department of WHO, it was really important to understand the role of regulation within the broader health workforce and the broader health systems agenda. Traditionally, and I believe ever since the Flexner report more than 100 years ago, regulation has been seen as primarily a lever to advance patient safety, to protect the public from harm in terms of ensuring the competency and of health practitioners and the quality of the services they provide. Now, that does remain a core function of regulation, probably the primary function of health practitioner regulation, but a contemporary regulation agenda cannot afford to ignore the broader challenges, the fundamental deep-seated challenges that the health workforce faces at large. These span a range of issues, including absolute shortages of health workers, with some countries having as little as 1/10 of the health workforce availability that WHO considers the bare minimum to attain a high level of coverage of health services. There are massive maldistribution challenges with access in rural and remote areas to health workers being a fraction, sometimes as little as 1 to 10 of the availability of health workers in urban and affluent areas. And that this maldistribution challenge is actually even more severe in the countries facing absolute shortages in the first place. So inequity within inequity. There are major issues regarding performance and productivity, again, even more severe in developing countries facing absolute shortages. So an exclusive focus on upholding high quality standards, while valuable and necessary in its own right, will not on its own address some of these other issues. So in reflecting on the body of evidence that has just been presented, and notwithstanding all the limitations that the team has clearly outlined, that we fully acknowledge and endorse together with the evidence gaps that warrant really upgrading the research, both in terms of quality and quantity and geographical origin. We did look at all this in the context of what are the possible entry doors for regulation to address broader health systems and health workforce challenges. And as a matter of fact, there are indeed many. Without going into details, I'll just give you some examples. For instance, on the issue of health workforce availability, there is a role of regulators in always striving for a proportionate approach, balancing the regulatory lever with the actual risk of harm, and avoiding placing excessive rigidities on the entry to market requirements, such as licensing, such as an overly restrictive scope of practice, because this can lead to a constraint on supply, which can translate ultimately into unavailability of health workers. And oftentimes these constraints are not upheld in the name of patient safety only, but other dynamics can get into the picture, including protection of professional turf and economic interest by occupations themselves. So this is a constant risk that regulators need to be vigilant against against avoiding and setting up their own institutional mechanisms in a way that avoids regulatory capture with the public policy objectives being always at the forefront rather than defending the interest of the professions themselves. Related to this, the scope of practice debate is also quite relevant. Oftentimes, it is not just about the absolute numbers of health workers. It is also about achieving a rational distribution of tasks and enabling health workers to practice to the full scope of their education and training within what they can safely and effectively deliver. This speaks to abandoning rigid occupation-based scope of practice, but rather basing the scope of practice on the actual competencies that health workers acquire. Another example is that of equitable distribution, retention in rural and underserved areas. It is not just a question for regulators, of course. There are employment conditions, there are working and living conditions that speak to even a broader agenda than what is within the direct control of the health sector only. However, there are also regulatory elements. For example, allowing an expanded scope of practice for practitioners working in rural areas who don't have necessarily the benefit of having access to specialist referral, or an enhanced career progression that some regulatory elements can go into that serves as an additional incentive, together with economic incentives, together with other aspects that relate to working and living condition, for practitioners to actually consider rural practice in the first place, and so on and so forth. A core challenge beyond numbers and distribution is performance. We have substantial evidence of poor productivity, particularly perhaps in the public sector in many countries. And there are performance elements that can be for which regulation can play a contributing role. For example, by having a more explicit governance and boundaries to dual practice, a challenge that affects both the working hours as well as the commitment and productivity of health workers that may choose to supplement their income in the public sector by taking on additional work in the private sector for remuneration. There is also the role of continuous professional development, which can be linked to licensing and relicensing to ensure maintenance of competency and improvement and updating of skills beyond the initial entry to practice requirement. There are, in addition, support functions that regulators can play, for example, through the availability of data that are captured in registry and feeding them into planning and monitoring processes to help steer workforce policy and strategic and investment decisions. And as was already alluded, ensuring that the health systems and the health workforces within them are also agile and responsive and can be resilient in the context of emergencies. The pandemic taught us about regulatory flexibility in terms of allowing different teaching methods, streamlining entry or re-entry requirements, facilitating mobility across jurisdiction, expanding or temporarily relaxing scopes of practice to allow the surge capacity required to respond to acute onset emergencies. So these are just some of the aspects in which I would encourage you all to think more broadly than simply patient safety, where regulators can also play a role, certainly not an exclusive role. This is very much in concert with planners, with policymakers, with employers, but where there is indeed also a stake for regulators. finally, in response to some of the elements that emerged from earlier interventions, of course, for WHO, it is always challenging to put forward a regulation when the evidence is not so robust. And I think Kate and Anne-Louise and Vivian were crystal clear. We are dealing with a large body of evidence, but largely descriptive in nature, with selective geographic focus and an income group bias within that. So we should not at the same time confuse absence of evidence of effectiveness with evidence of absence of effectiveness, if you allow me the play of words. There are elements on which indeed the evidence body is not matured to the point of linking regulatory structures and mechanisms and interventions with outputs, with outcomes. This is an important element to reflect on in terms of future research. At the same time, when approaching this in line with the WHO methodology for developing normative guidance, we looked at plausibility of contribution. We looked at indirect evidence. We leaned, of course, also on the expert opinions within the technical expert group. And we do have, across all the areas that I mentioned, at least some recommendations in terms of what policymakers and regulators can consider in these various dimensions. An important element to highlight, however, is how context specific all this is, and therefore beyond the broad principles, the understanding of local reality, local implementation capacity to design regulatory mechanisms and responses which are best suited to address local needs and can be relevant and feasible in a local context. Within this, one particular element that I would like to highlight is an acknowledgement of a regulatory practice gap, that oftentimes regulation remains on paper, but doesn't necessarily translate into the regulatory actions that the paper describes. And this is one of the reasons that part of the recommendations relate not so much to the contents of regulation, to the actual functions of regulations, but also to the institutional arrangements and the governance mechanisms for regulators themselves in terms of their institutional setup, the role of government oversight, the issues of managing conflict of interest and regulatory capture, and crucially, the appropriate staffing and resourcing of regulators themselves. These are aspects that will be also addressed by the forthcoming WHO guidance. With these initial thoughts and considerations, I hand the floor back to you, Jean, but I'd be happy to take on questions later on. Thank you.
Thanks. Jishnu Das, who is a member of the technical expert group, will give his perspective on this.
So I want to talk about a part of the report that I think is really important and often missed, which is, there's a lot of regulation on paper. There's a lot of regulation that countries do undertake. But if you want to take a look at kind of how these regulations play out, I think the first step is to take a look at what really happens in practice. And I want to just share with you 3 slides of work that has emerged over the last 20 years. And in a way, this is work that's not very complicated conceptually, but it's very costly in terms of shoe leather. So let me just show you these 3 big slides and then perhaps open up for questions. So the first slide I'm going to show you, so every country tries to regulate entry into the medical force, or at the very least, set in place processes that allow them to make a statement that doctors are qualified medical professionals who are providing higher quality care than the alternatives, right? And the regulatory practice gap really says that there's actually a big distance what regulation intends to happen on paper and what happens in practice. So let me just share with you kind of three big results that are emerging from this literature, of which I work on quite a bit. So the first result is, quality in low and middle income countries, and we don't have equivalent results from high income countries yet, can be very, very poor. And the way that we have done this is we have used standardized patients. So these are people extensively trained from the local community to present to multiple healthcare providers, the same presentation. And the presentations are very, very simple. I mean, for example, one presentation is a person with a heart attack, right? Another presentation might be a person with very obvious signs of asthma. So here are the results from multiple studies. And I'll just point out to you that, look, the numbers we are finding are very problematic, right? So, here, for example, are samples from India. These are samples from India as well. And always we are finding that these patients are correctly diagnosed or treated in fewer than 50% of cases. And remember, these are not complicated cases. This is a person showing up saying, hey, I woke up in the morning with a crushing chest pain and, extreme anxiety. And if the doctor asks further, the person would say, my father died of a heart attack, I had a shooting pain down my arm. These are not cases trying to trap doctors. These are cases where we're genuinely trying to find what people do. If you look at a condition like tuberculosis, which is being tried now in multiple places, again, fewer than 50% of patients are being diagnosed or managed for cases like this. And on the other hand, all of the cases don't require antibiotics, and you see like antibiotic use is very high and typically greater than 50%. So that's kind of the first big result that's emerging, which is we really have a problem with the quality of care, right? Second big result that's emerging is when you start to think about how competent healthcare providers are, the idea that we can use doctors per thousand or that doctors conveys quality runs into two big issues. The first big issue it runs into is who is a doctor and how competent they are really varies across countries. So we have now done this in now 15 countries or so, where we've used medical vignettes or clinical vignettes to look at how knowledgeable doctors are, right? So let me give you some kind of ideas from there. So in all the sample of countries that you see here, which are all from sub-Saharan Africa, Kenya and Malawi have very, very high quality doctors, right? People who are doctors typically tend to do pretty well, right? And the score here I'm looking at is just a standardized score, but think about it as saying, if you're about 1, you will diagnose, 10 conditions that we test about 80% of the time. If you're at about -1, you'll diagnose them about 40% of the time, right? Think of something like that. And you see that the Kenyan average is really much higher, say, than the average in Mozambique, right? And that's for a doctor. The second, what knowledge a doctor has really depends on what country you're talking about, right? Second big problem is even within a country, there's just wide variation in knowledge and competence. We don't know why. Maybe it's because of where you trained, or maybe because of how you did. But what we've tried to do here is say, hey, let's just look at how many doctors are actually more competent or medically knowledgeable than the median Kenyan nurse, right? And in Kenya, that's 70%, not 100, but not 20 either. In Guinea-Bissau, that's 30%, 38%, right? So doctors, the majority of doctors in Guinea-Bissau are actually less medically knowledgeable than a Kenyan nurse, the median Kenyan nurse, right? In Madagascar, it's 37%. In Mozambique, it's 41%, right? So really, there's this massive gap between what we think regulation is doing in terms of entry into the medical force and what's actually happening and in the way that these things are playing out. Regulation is not leading to a standardized workforce either within countries or across countries, right? Final slide, and this is, I'm slowly trying to introduce this. Doctors are massively underworked. And this is something that people are having a really hard time understanding, right? You can have few doctors per 1,000 population, but they can still be massively underworked if they're in the wrong places. So let me just show you the data, right? These are the number of patients per clinician per day, right? They've been very carefully calculated. In Nigeria, it's 2. The average clinician or person in a public health primary clinic in Nigeria is seeing 2 patients a day, right? Across all these countries, and now we have done this for Vietnam, we have done it for Peru, we have done it for India, we are finding the same results. Almost in no country is the average caseload greater than 10 patients per day. So our time motion studies are consistently showing that doctors are spending 2 to 2.5 hours a day seeing patients. The rest of the time is idle. They're sitting there without having patients coming in. The numbers are really low in places like Tanzania, Togo. They're slightly better in Kenya, slightly better in other places, but we seem to be wasting a huge amount of resources in the way that doctors are placed and the amount of providers they're seeing. So I want to stop there because I think these are enough to debate. But my main issue with thinking about the way we envision a lot of stuff in global health is the debate seems to proceed somewhat orthogonal to what the basic facts on the ground are, right? And I'd be delighted if somebody said, no, we did this other survey and here's why these numbers are wrong. But it seems to be more a question of perceptions rather than actually what's happening on the ground. And I think grounding the evidence and saying, hey, let's make sure that we debate these things, but we debate them within the confines of the basic facts that are available from surveys on the ground is, I think, a really, really important piece. And I think this is what I found fascinating about this report is the willingness to take on and address the fact that, yes, we can have a lot of regulations, but it's been really hard to put them in practice, really hard to think about how they percolate through into the health system at the level where they affect patients. And I think that's one key issue that the report brings out and that I think will have a big impact on the way we think about this moving forward. So let me stop there. I'll stop my screen share and hope that was helpful.
Thank you very much. That was quite thought-provoking. So we have an opportunity for questions. Do we have any questions from the audience? I think they're still digesting your your work, Jishnu. So I have a few questions I would like to ask. So first to Kate Leslie. This report was done at a pretty interesting, or I'm sorry, the research was done at a pretty interesting point in time. And many things have changed since then. So Kate, can you talk about some of the new regulatory research that your team has been doing and what sorts of things you're looking at seeing?
Sure, I can mention a few things, and I'm sure other panelists might want to chime in on this too in terms of some of the more recent research and things that we've been doing. On some of the teams that I'm working with, we've been looking at one pillar of research around the impact of technology on regulation. And I'm finding this really interesting from sort of 2 aspects. One being how regulators are regulating the practitioner's use of technology in practice. So if a nurse is relying on artificial intelligence to triage a patient, where does the accountability lie? So that, that type of interesting elements in terms of how regulators are responding to that, and also the impact of technology on regulatory processes. So some of the research that we were finding was just starting around data analytics, and can regulators use some of the data that they have to predict what practitioners might be most at risk of competence concerns later in practice or something like that. So we're finding that really interesting. And I think Vivian was mentioning around the idea of learning from outside of health practitioners. So the research that we've been doing is looking at beyond just health regulators. We're looking at legal regulators, education, engineering, like different sectors as well, and finding a really very diverse response to technology among different types of occupational groups. Certainly among legal regulators, we're seeing some really advancements around things like regulatory sandboxes. So, safe ways of looking at innovative legal technology that previously only qualified legal practitioners could do. How do we regulate that in a safe space? So those types of initiatives and innovations we're not seeing as much in health. So we're doing some cross-comparative work there. In Canada, we're just briefly another team that we're doing, and I think some of the members of the team are in the room in Ottawa today. We're looking at mental health and substance use health service providers and how this really critical workforce is being regulated in Canada. Certainly, we're seeing very diverse elements of regulation, for across a whole spectrum, and it's very sporadic and variable between Canadian jurisdictions even. So we're looking at what the impact of that is on equitable access to care. So certainly in something like substance use health or addiction care, we're seeing some political ideologies and stigma coming in that really impacts then on regulation, which in turn impacts on equitable access to care. So I think those are a couple of the sort of fields that we've been working on in our team. Happy to connect with anybody about other areas as well that are some sort of new and emerging innovations that we're trying to keep track of. Thanks,
Thank
Jean.
you. Ivy, you indicate there is a question from the audience?
Absolutely. So please go ahead and make sure to introduce yourself.
Hello. Oh, it does. I'm Steve Slade. I'm the Director of Research at the College of Family Physicians of Canada. Hi, everyone. Familiar faces, old and new. I guess I have a question from the literature there. I guess looking at the regulatory function around licensing, this sort of just checking that qualifications are in place and there's training has been achieved that would make you competent to work as a worker. I see that as a function. I heard that very much in your comments. The regulatory function, where there's an avenue for patients and peers and the public to lodge complaints and to have those complaints investigated, and then for there to be some justice, I guess, exacted where it's appropriate. This is a function of the regulator. And then this remediating, I guess it's within that sort of that circle of regulating where remediation is needed, where there's been a decision of finding, and then to remediate that in some way, whether you're struck off the register or you are required to get training that remediates the complaint that was found to be true. So these, I think, are the traditional functions that we see of regulators. And what I'm hearing is, in some of your comments, an extension of that to achieve certain ends and goals that relate to the workforce. Some of them very clear, just providing data, so the regulator gathers data. Why not just make that data available to researchers, planners, decision makers, and so on? I see that. But where it's a little bit more of an active role, when and please don't take my words wrong, I'm not making an argument for anything in particular, but where certain equity, diversity goals are sort of seen as being perhaps things that could be moved through the regulator. I do wonder if the literature is showing, do regulators ever achieve that? Are they shown to be effective, as opposed to legislative sort of solutions where government gets in there and you look at things like how do you do training, your health education? Are there strategies within those domains to sort of, bring in a more diverse workforce and so on? So I'm just wondering if the literature says, do those traditional roles of the regulator suffer when you extend the regulator's role? And when the regulator does that, is it actually an effective means of achieving those social aims, as opposed to other strategies that you might pursue outside of a regulatory sort of role?
So who on the panel would like to answer that?
I can have a go.
Yeah, go ahead, Anne-Louise.
Okay. I think the short answer is we don't know. We didn't find much literature that evaluated the effectiveness of regulators' traditional functions, let alone these extended functions. And certainly in the comparative mapping that we did of regulatory powers and functions across about 20 jurisdictions, which was a component of the research that we didn't mention, but is certainly in the report, we also did not find in the suite of powers and functions of most regulators those expanded functions that you've identified. So it's hard to tell. I certainly know in my own experience where our regulators in Australia have had these multiple functions, responsibilities in terms of workforce goals and education goals, as well as protecting public health and safety, that there have been at times tensions in how they try to achieve those. But having said that, certainly in the last conference that I attended, the International Association of Medical Regulators, one of the strong themes in presentations at that conference was certainly an indicator that the regulators do see themselves as having those broader responsibilities. And, lots of regulators, as far as I can tell, have competing objectives that are sometimes in conflict that they have to navigate in order to deliver their functions. So I don't think it's necessarily problematic. I think we'll see more literature coming out in the future about how effective regulators are in addressing racism in the health system, or ensuring cultural safety, or addressing inequality, because they do have levers where they can use to influence those things. There's no doubt that they can influence those things. And there's more and more of an appetite, as far as I can tell, to do that.
Great. Thank you, Anne-Louise. Giorgio, any thoughts on the point about leveraging the data regulators collect for workforce planning? I think what I've seen personally is that there tends to be a lot of resistance to that, the sharing of data and effective use of it. What are your thoughts?
Thanks, Gina. I would agree that there is an untapped potential in terms of leveraging workforce data available to regulators for policy and planning. Part of the challenge lies perhaps in the most obvious concern, which is around confidentiality. But that, to a large extent, can be overcome through appropriate mechanisms to ensure anonymity. Ultimately, the policymakers, the planners would not necessarily need the individual level data. It's the aggregate data that would inform the macro planning. At the same time, while typically at least the stock data tend to be shared, there are probably opportunities for incremental improvements in terms of additional data field that are available to many, if not most, regulators, such as age, or that is to monitor cohort and the demographics within the workforce itself, or place of employment, employer type. These are information fields that many regulators hold, but that will be really valuable for planning and monitoring, and that do not necessarily get factored in or do not get shared. So I think part of the answer probably lies in developing frameworks at the national level for data sharing, which can be instrumental in allaying some of these concerns, because ultimately it doesn't need to be necessarily tension between the role of regulators and that of planners. At a more technical level, there are issues about the interoperability of different platforms. Oftentimes, there are different ones operating within the same country. The payroll data do not necessarily speak to the regulators' data that in turn are different than those available to planners, or the format that planners and managers would make. And these are aspects that require a conversation in terms of the IT platforms. But if I may just add a quick thought on the earlier question as well, I think part of the challenge is that oftentimes the literature and the evidence doesn't exist purely in the context of regulation, but we do have some examples, for example, in the area of retention, whereby it is not to say that regulators need to keep health workers in rural areas. Obviously, the primary responsibility lies with employers, but there are regulatory elements within that, and we do have evidence of the greater effectiveness of these strategies if they are implemented as a bundle. If the education element come together with the employment element, together with the regulatory elements, the combined effects of different policy management and regulatory lever is greater than the sum of the individual parts. And that's part of the rationale why WHO recommends these as bundled interventions instead. We don't have that level of evidence across all the areas, and in some aspects it is still emerging. However, this is a direction that I would encourage us to collectively think toward. Thank you.
Very good. Thank you. Joining us this morning is Sir Harry Caton, who led the UK Professional Standards Authority for a number of years. Greetings, Sir Harry. We go back a long way. So I think it would be interesting to get your perspective on this work and your thoughts about it.
Thank you, Jean. Well, my perspective is quite simple. I think this is a brilliant and important piece of work, and I just want to congratulate everyone who's been involved in it. Nobody has attempted this before, and notwithstanding all the caveats you correctly make about the validity and the robustness of the evidence, this is the best we've got at the moment, and nobody has produced anything better. And it will be inspirational, I think, for researchers to take up some of the issues that you have raised. So I really just want to say congratulations. I want to say congratulations to WHO and Giorgio and his colleagues, and to the review team. And I'm impatient, I have to say, Giorgio, to see the final policy report published, which I know we will get soon. I just want to make one comment, because I thought Vivian Lee made a really important point that we do need to bear in mind, which is the dangers of regulatory colonialism. The danger that because the power and the wealth still lies in the Western model of regulation, the Western model of delivering healthcare, that we need to beware of the danger of imposing that as a rigidity on different cultures and different economies and different health systems. And I know that's part of the response of the work, but I just think it's really important from my perspective to stress how important cultural sensitivity needs to be. But thank you for the opportunity. It's been really interesting, and thank you for the opportunity.
Thank you. Ivy, we have a question from the audience.
Yes, and please introduce yourself.
Okay, it's on now. Okay, I'm Arthur Sweetman from McMaster University. So I know this is a session on health practitioner regulation, but I want to push you to the margins of health practitioner regulation. So one of the things we talk about in Canada is the trade-off between regulating occupations or professions and regulating employers. So recently there's been a lot of debate, well, a few years ago, a lot of debate pre-COVID about regulating certain lab workers versus regulating the hospitals. The hospitals really wanted the province or provinces to regulate the workers because that shifted liability from the hospitals to the workers. So they thought that was a great thing. Shifting liability was good, but in some sense, the lab is part of a system. And if we remove responsibility from the employer, there might be some cost to that. So I wanted you to, if there's anyone willing to, Giorgio talked about this just a little bit in his remarks, but to think about the trade-off between regulating employers and regulating workers. So one of the examples we give here in Canada is that our public health licenses restaurants and not cooks because they want the responsibility to lie with the restaurant because it's a system. And if you regulate, if you put responsibility on the cook, you're removing responsibility from the person who manages the entire system. So I want you to think about that. I just want to know if any of you have any opinions on that trade-off between regulating occupations and regulating employers.
Thank you, Arthur. Over to the panel.
I'm happy to have a go at that one. I think in the report, we placed a lot of emphasis on regulatory management systems and good regulatory practice, because I think the questions that you ask about, is there a need for multiple layers of regulation, and if so, why, is a question that is addressed when you do a regulatory impact assessment, because you have to go through a process of identifying what's the nature of the problem that you're trying to fix, what's the existing arrangements, including the regulatory arrangements, what's the objectives of government action, and what are the alternative options, and including the status quo no change, and how you and then comparing those options and the costs and the benefits. So yes, I agree. There are some occupations where why would you bother registering them or licensing them when you already have accreditation of pathology labs or health facilities licensing as a mechanism where the staffing profile is part of the, examination, assessment of the staffing profile is part of the licensing of the facility and is assessed through that process. Having said that, there are some professions where what they do is so risky that it helps to have several sets of eyes scrutinising. And we know we've had regulatory failures. I think it's the Swiss cheese model where the failures are in successive slices of the cheese and successive failures of various regulators. So having multiple sets of eyes, so you've got a better chance of identifying where practitioner failures are indicators of health system failures or health service, broader clinical governance failures, is important. But yeah, I agree. That's an important part of regulatory assessment process.
Thank you. We also have joining us this morning Doug Bilton with the Professional Standards Authority, who had actually sent in a question under Q&A. Welcome, Douglas. We would love for you to share your perspective and ask your question.
Many thanks, Jean, and it's really it's great to be here this afternoon for me, and to also just to reflect on Harry's and others' comments earlier. This is a fantastic piece of work, and I think it's a real milestone in understanding the different approaches to regulation internationally and what they are setting out to achieve. My specific question to the researchers was, reference was made to evidence of increasingly regulators taking a more risk-based approach to the regulatory task. The question is, does that include assessing risk in decisions about which forms of regulation, whether that's statutory regulation or a voluntary scheme, are the most appropriate for any particular part of the workforce, any particular profession, or any particular occupational group? In the UK, at the PSA, we've begun to develop an approach to that, which we've called right touch assurance, which some in the audience may be familiar with. But I was wondering whether the researchers had found any other similar attempts around the world to answer that particular question. Thank you.
I can pop in very quickly here. I bet Anne-Louise will probably have some thoughts as well. Thank you so much, Douglas. Yes, just in terms of the Canadian perspective, we did find that there was the idea around assessing risk and finding the right touch in terms of regulation came out more clearly in some of the reform, especially in more recent years. And in some of the work we did where we interviewed, speaking about other projects as well, where we interviewed regulators, they spoke very eloquently about wanting to find the right touch in terms of their regulatory processes and functions. And that was, within internal processes to ensure that what they were doing, was getting the balance right. We heard that over and over, trying to strive to find that balance in terms of different processes that they were undergoing. And this was in reference to as well for internationally educated providers and the registration requirements and some of the need to change processes for both domestically trained applicants and internationally trained applicants to ensure that there was enough workforce. So some of the need to shift a little bit to address the workforce challenges may change some of that balancing. And we found that was coming across loud and clear. We're seeing that in some of the legislative reforms, certainly in the new legislation coming in British Columbia. There's a lighter touch model being introduced for lower risk categories of occupations. So we're seeing that I think seep across from the right touch regulation model as well. I think Anne-Louise, you might have some other examples too.
Yes, thanks, Kathleen. We quoted you'll find in the report we address these questions of how do governments make decisions about the most appropriate type of regulation, given the risks associated with a particular health occupation. And we do point to right touch regulation and that document published by the Professional Standards Authority as one approach. And we've also mapped done a comparative analysis of different policies and criteria and processes adopted in different countries to try and draw out the key features of those processes, but ultimately have come back to the importance of good regulatory management, good regulatory practices, and a regulatory impact assessment as the best established, most developed methodology for making those sorts of decisions where you have to demonstrate, you have to assess the costs and the benefits of a range of options and identify the option with the greatest net benefit before making a decision to introduce a new regulation.
Excellent. Thank you very much.
We have one question from the audience, and Andre Garapi would also like to make a comment about this topic. So Ivy, do you want to go with the question we have from the audience?
Hello, Margaret Walton-Roberts from the Canadian Health Workforce Network. Thank you so much for this panel. Fascinating to listen to all of the presenters. I have a question in some ways that's informed by Vivian's comments about the focus that needs to happen in terms of low and middle income countries. But I wondered, though, I'm interested in what's actually happening in high income countries in light of recent transformations in terms of health service delivery and unregulated service deliveries. We heard yesterday about the rise of DIY dentistry in the UK, and there is evidence that there are unregulated practitioners in this field in part due to the kind of failure of adequate support for dentistry for the population. And I'm also deeply worried about what's going to happen in the US in the post-Dobbs landscape. I would be very interested to know if the panelists have comments on that. I mean, especially thinking about the potential for unregulated perinatal and maternity care for those who are really unable to access adequate service of care in the current US political climate. Thank you.
Any
That sounds like
takers?
it sounds like it's a mic drop. So would anybody like to touch that one? Vivian, would you like to, sorry to punt that to you, but I think part of it was to address to you.
Well, I was actually going to dob in Anne-Louise in terms of the negative licensing as one approach for certain things, but also this issue about whether you're regulating use of titles, regulating scope of practice, and whether some of these issues might be helpful.
Okay, thanks, Vivian. I think what Vivian's referring to is a scheme that operates now in 5 Australian states, where there's a regulator that there's a code of conduct that's made by regulation. It applies to anybody who provides a health service who's not registered or licensed under the National Registration Accreditation Scheme. And the regulator has powers to receive and investigate a complaint of breach of the code. And if the breach of the code is serious enough and there's a future risk of harm to the public, then they can issue a prohibition order. The prohibition order can attach conditions to the practitioner's practice or can remove them from the workforce altogether. And so if you've got unlicensed or unregistered dentists or people doing risky things for which they're not qualified, that would be a breach of the code of conduct, and the regulator would have powers to remove that person from practice if the risk was serious enough. And there are offences punishable by up to 2 years imprisonment for breach of a prohibition order. So this really covers all the unlicensed, unregistered, non-registered healthcare workers who are not subject to our licensing scheme. So we've got, in our view, we've got the field covered, and these regulators are doing a lot of work in our system. There are hundreds of prohibition orders that have been issued, including during COVID, for people who were spreading misinformation about vaccines and encouraging people not to vaccinate. So I think that occupational regulation, you've got to look at the suite of tools that are available to make sure that you've got those circumstances covered. But I also think you've raised a broader issue about universal health coverage and how well it's working. If it's throwing people into poverty and they're choosing not to use health services because they can't afford it, then that's certainly a concern that all countries are working to address.
Thank you. Finally, we will hear from Andre, who wanted to weigh in on this. Go for it.
Hello, everybody. It's good to see familiar faces from around the world. So, as a member of the technical expert group behind that work, for sure it was something that it was a dream come true. Since I've been involved in professional regulation for 30 years. And I remember the first few meetings where we kind of sensed that we needed to be humble. Meaning that to avoid colonialism, to avoid dominance, standard dominance, even besides colonialism, even between the so-called developed countries, they're fighting between each other whose standard will be the one that will be imposed on everybody. So we need to be humble between traditions, between professions also. We need to be humble even between jurisdiction in one country. So we need to be very careful because no one has the clear evidence. And for sure, regulation is like a fire station. It's good to have a fire station. It gives some assurance, but because there's a building, there's trucks and everything. But how do they do their work? Are they efficient in fighting fires? So we need more evidence. But for sure, we tend to think that we need a fire station. We need a kind of setup for public protection somewhere. So and by being humble, and you will see in the guidance, it means that here's the ingredients that we used. Well, use it, make your own recipe, add a few spice if it's within your tradition, your local context. If it answers the need, the health needs in your own situation. But overall, this is what we can bring to you. And for me, it is only a start. Like when we ended the work, and we're still waiting for the bureaucracy from Geneva to process, and Giorgio is right in the middle of it. And I don't envy your position at this point to push the system to finally publish that document. But at the end of our work, we all said, well, this is only the start, because we see the need for further research, further evidence, further knowledge being brought from different countries that never documented what they were doing. So this is only the start, but it's very, very positive. And we were not sad about the lack of many things. We were hopeful, and because there's a need for it and there's a will for it. So I will answer maybe Arthur's question about going beyond the practitioners and maybe employers or institution. Well, some professions outside health and in health has made some advance in looking at the context of a practitioner's work. And we have some provisions like the accountants, and some of the health professions. We have provisions in the legal system in Quebec so that we can look beyond the practitioner's work and look at the unit, the institution they're working in. So, and being able to address those institutions, some recommendations, so that the entire team of professionals working there will be better supported and have a better environment to provide quality care. So you have some elements somewhere, but make it a more broader approach. That's something to think about. So again, thank you very much, all these people, and I can't wait to have the guidance. Like I said to Giorgio a few days ago, I preach on it, but people would like to see it to believe it.
Very good. Thank you so much. So we are a little over time. I think we're going to have to close, and I just want to thank the panel. This has been an excellent, excellent session. I've looked at and studied scope health professions regulation for many, many years, and what a great way to draw attention to this incredibly important topic. Ivy, over to you.
So thank you, everybody. A round of applause from the audience here and online. And we'll be taking a 12-minute break and getting started right at 9:45 for the next panel. We invite you back. So thank you again. Thank you to all online.